So the kind of conditions that people might have that lead them to a point where they may need rotator cuff surgery are, of course, people with rotator cuff tears. But lots of people have rotator cuff tears. In fact, the vast majority of very old people have rotator cuff tears. So what we have to try and work out is whether the kind of tear that you as a patient have is one that you would benefit from having an operation. So for example, if we thought you didn't have a rotator cuff tear and then you have an injury and now it's torn, that would be a good indication to repair it. Whereas if you're elderly and you had a minor injury and now got a rotator cuff tear, well, probably the rotator cuff tear was there already or nearly there already, in which case we probably wouldn't choose to repair it. So most people that end up having rotator cuff repair surgery will have already tried a variety of different treatments, for example, injections, physiotherapy, given it some time to see if it settles down. And then if all those have been tried and don't work, then rotator cuff repair surgery is a very good and reliable option, particularly for improving pain and improving function. So rotator cuff is a name that we give for a big group of tendons that are deep inside the shoulder, which attach to a bone at the top of the shoulder and which are responsible for moving our arm up and down. And these tears are big and thick and they're very elastic, so when they tear they ping off the bone and they stay away from the bone, and there's no amount of time or physio that will draw that tendon back onto the bone. So once it's torn, you have to make a decision. Are you just going to live with it and accept that it's torn and it'll be torn forever, or whether you have an operation to pin it back down, because that's the only way to restore the continuity of the tendon. So during rotator cuff repair surgery, almost always this is planned as day surgery, that is, you'll be in and out on the same day. You'll be done under general anaesthetic, that means you'll be asleep for the operation, and 99 times out of 100 we do it through keyhole surgery. Now if you've got a huge rotator cuff tear and it's been there a long time, it may be that we'd have to use a more traditional open approach with a big cut, but we would discuss that with you and whether or not that's relevant. Almost always, however, we do it with keyhole surgery. And what that means is having you asleep, we put a telescope into the shoulder while you're asleep, have a good and careful look around and make sure we properly understand what's going on. I grab the torn tendon edge and make sure I can pull it back to where it's meant to be. And as long as I can, then we use what we call anchors. They're like headless screws that we can screw into the bone, and then they've got stitches that are bonded to that screw. And we can weave those stitches through the torn edges, and then as I tie the knots, it draws the tendon back down and pins it back down into place. And it's an operation we do regularly. Usually takes about 45 minutes to do in most cases. And when we finish, there are no stitches on the outside, it's all done keyhole. These are little scars that are going to heal without the need for stitches. In terms of keyhole surgery, that's something that we can do for the vast majority of people with rotator cuff tears. But there are a small proportion of people for whom it's not technically possible to perform the repair adequately using keyhole techniques. And there are some limitations to keyhole techniques. And therefore, if you have a very big rotator cuff tear, and we would establish the size before we start surgery, so either through an ultrasound scan, which is very accurate, or sometimes we use MRI scan. But if we've established that it's a very big tear, it's very badly retracted, and the quality of the tendon doesn't look good, then in those circumstances, I would prefer to plan that we do an open surgery operation. And that means, again, having you under general anaesthetic. It means using a more traditional cut through the skin rather than just through keyhole. And then we can look and see the size of the tear, and we can suture it all back together again. And sometimes even we sew in a little patch of material, if you like, to help improve the quality of the tendons that we've just repaired. So following surgery, whether you've had it done open or arthroscopic, we would expect that you'll probably be able to go home on the same day. Now, in the vast majority of cases, you will be expected to wear a sling for 6 weeks after the operation. And that is a real bind. For most people, that's the most difficult bit about engaging with the whole operative experience. It's not so much the surgery, not even so much the general anaesthetic, but rather the fact that you're going to be bound with one arm for 6 weeks. You can still use your hand is available, so you can still cut meat and tap on the keyboard and use a phone, but there's no doubt it's quite encumbering. And for many people, the big issue is that you're not allowed to drive for that 6 weeks. It's illegal to drive while you're in a sling. So whether you've got an automatic, it doesn't make any difference. You wouldn't be allowed to get behind the wheel of a car. And that therefore has an impact on when you might be able to return to work, because if you need to drive to get to work or you need to drive to do your work, then you may have to plan to take quite a long time out of work. Whereas if you've got alternative methods of getting to work, and if you're a desk-based or non-manual worker, actually you'll probably be back at work within 10 days or 2 weeks, albeit still in a sling. So the causes of rotator cuff tearing are varied, and there seem to be multiple factors at play. And probably the most important thing is age, and that is that young people almost never get rotator cuff tears, and very elderly people almost all have rotator cuff tears. So on your journey through your life, the chance of you developing a rotator cuff tear increases as you get older, and presuming that's to do with the quality of the material of your tendon, it just gradually degenerates as you get older and therefore becomes more likely to tear. The other reason is genes, that we know from some really nice research done in Oxford that there's a genetic component to whether or not your rotator cuff is likely to tear. So if you have family members with rotator cuff tears, you yourself will be at higher risk of also developing a rotator cuff tear. And then other factors definitely contribute, so that if you are a heavy manual worker, you're more likely to get a tear than if you are a desk-based worker. If you're right-handed, you're more likely to get a tear on your right side, so presumably that relates to increasing use. And then the other major aspect is trauma, whether you injure yourself. And the injury almost always is if you fall and try and break your fall by putting your arm out. And it's not uncommon for people to have really nasty falls, perhaps off their bike or perhaps slipping on ice, fall heavily, try and break their fall with their arm. There is so much pain, they wonder whether they might have broken something, a bone. They go to casualty, they have an x-ray, and they're often falsely reassured. No, don't worry, your x-ray's fine, you haven't broken a bone, you must just have a sprain, go home, it'll get better. And this is poor advice that I'm afraid a lot of my patients receive. Certainly if you're over 40 and you've had a major injury, a heavy fall, and you've got pain and a normal looking x-ray, we have to assume you've torn your rotator cuff till proven otherwise. And in those circumstances, you really need to get yourself in front of someone like me, a shoulder surgeon,